Welcome back to the deep dive. Our mission today is absolutely critical. We're focusing on a diagnosis you will encounter, everywhere. Every clinical rotation, every specialty, diabetes mellitus.
This is unavoidable.
Right. But we aren't just, reading off facts here. We're taking a whole stack of source material and really filtering it down. Specifically for the nursing student perspective, we want to pinpoint and amplify that high-yield information, the diagnostics, the treatments you need to know, and maybe most importantly, the priority nursing interventions.
Exactly. That's the focus.
Yeah.
Efficiency and, frankly, clinical urgency. Because if you're a student prepping for an exam or, stepping onto the floor for the first time,
Yep.
you absolutely need to know which numbers mean stop what you're doing and intervene, like right now.
Okay.
You need to get the why behind the treatment plan.
Yeah.
And understand how your basic nursing care, especially the teaching you do about, say, acute complications or long-term prevention, how that really holds the key to preventing, well, disaster sometimes. So we're moving past just definitions today. We're going straight into actionable clinical priority knowledge, what you need to do.
I really appreciate that focus on actionable because let's be honest, when you're looking at a patient's chart or maybe assessing someone who's clearly symptomatic,
Yeah.
knowing that specific number, that line in the sand, that cutoff, is really the difference between just routine care and potentially a full-blown crisis management situation.
Yeah, it absolutely is.
Yeah.
That number triggers everything else.
Okay, so let's unpack this, starting right at the beginning with the cold, hard facts.
Huh?
How is diabetes mellitus DM officially diagnosed? Before we even start thinking about treatment, we gotta know the rules. What are those essential criteria, those 4 things that confirm it and really set the direction for care? What are those specific threshold numbers that every single student just has to have memorized?
Right. And they are non-negotiable standards.
Yeah.
These 4 lab criteria, they confirm that there's an established metabolic problem happening.
Yeah.
And understanding these numbers, these thresholds, is just essential.
Yeah.
Because they're the objective proof, They tell the patient, the doctor, and crucially the nurse that, okay, we need serious management here.
Got it. So what's the first one?
Okay, the first one, you often see this used in the emergency room or maybe an urgent care setting because it requires the least prep,
Quick and dirty?
Kinda, yeah. It's the simultaneous presence of those classic symptoms plus a random blood glucose, a BG reading that's over 200 milli-GDL.
Okay, so classic symptoms, we're talking polyphagia, right?
Yeah.
Excessive hunger, polydipsia, excessive thirst, and polyuria, excessive urination.
Exactly. Those 3 polys.
So if a patient walks in, maybe they're saying, I'm drinking gallons of water, I'm going to the bathroom constantly, and you check their finger stick and it's, say, 215.
Boom.
That's it. Diagnosis confirmed, just like that. No need for another test.
For that first criterion, yes. That combination, the classic symptoms plus a random BG over 200, is a pretty rapid confirmation right there.
Wow, okay. What's next then?
All right, moving to something a bit more controlled, more of a baseline measure. The second key number involves fasting.
Okay.
The patient has to have fasted for at least 8 hours. No foods, no sugary drinks, just water is usually okay.
Right.
For a diagnosis of DM using this method, the fasting blood glucose, or FBG, has to be 126 milli-GDL or higher.
126. Okay, clinically, why that specific number? 126, it feels kind of close to normal, doesn't it? It might almost brush it off.
That's a great point, but 126 is actually a really critical threshold. It tells us something fundamental about the body's basal metabolic control.
How so?
Well, think about it. If you haven't eaten anything with glucose for 8 solid hours, and your liver is still churning out enough glucose, or your body isn't using insulin effectively enough to keep your blood level that high,
Ah, okay.
it signals a failure in those basic regulatory mechanisms, especially things like how much glucose the liver is making when it shouldn't be, or how well your baseline insulin is working.
So seeing an FBG consistently over 126 tells the nurse.
It tells the nurse that lifestyle changes alone. Probably not going to cut it. We're likely looking at needing medication soon.
Okay, that makes sense. 2 down. What's number 3?
Number 3, it looks at how the body handles a sudden sugar challenge. It's the glucose tolerance test, or GTT.
Right, the one where you drink that really sugary drink.
That's the one. It basically measures how effective your insulin is and how well your cells take up glucose when there's a big load.
Okay.
So the patient drinks a standard glucose load, and then we measure their plasma glucose level 2 hours later. If that 2-hour reading is greater than 200 milli-GDL, that's also diagnostic for diabetes.
So that test is really directly measuring the body's failure to clear sugar efficiently?
Exactly.
Normally, insulin should surge, pull that sugar into the cells, and the level should drop significantly by 2 hours if it's still over 200.
The system's clearly overwhelmed. Your insulin response isn't adequate for the challenge.
Got it. And the last one, number 4.
And finally, number 4. This was arguably the most important for looking at long-term control and overall risk. It's the hemoglobin A1C.
Ah, the A1C. Everyone talks about this one.
They do, and for good reason. This isn't just a snapshot like the FBG or the random BG. This test gives you a look back over the past, say, 2 to 3 months.
Right, like an average?
Pretty much. For diagnosis, the A1C value needs to be equal to or greater than 6.5%. So A1C 2 peri 6.5%.
Okay, so if the FBG and the random are like single photos, the A1C is more like a time-lapse video.
That's a great analogy, yeah.
Why does that chronic elevation show up in the A1C? How does that work?
So hemoglobin A1C measures the percentage of your hemoglobin, that's the protein in red blood cells that carries oxygen, that has glucose basically stuck to it. It's a process called glycation.
Okay.
Red blood cells live for about, 90 to 120 days. So the A1C reflects the average amount of glucose those cells were exposed to over their lifespan. If your blood sugar has been consistently high over the last few months, more glucose sticks to the hemoglobin, and that percentage, the A1C, goes up.
And the beauty is, it doesn't matter if you were stressed that day or skipped breakfast or had that donut.
Exactly. It cuts through that daily variability. So if you, as the nurse, see an A1C of, say, 7.5%, you know immediately this patient hasn't been well controlled for months.
And that instantly flags the need for, what, more education, screening?
Both. Definitely intensified patient education and absolutely screening for potential chronic complications, because that level of chronic high sugar does damage over time.
Okay, let's connect this back to the clinic floor again. Say a nursing student sees a patient, their chart shows an FBG of like 120 milli-GDL. That's just under that 126 diagnostic line.
Right, technically pre-diabetes.
Yeah. But clinically, wouldn't the nursing advice, eat better, exercise more, be basically the same as for someone who just tipped over at 130? Does hitting that official diagnosis number change the immediate nursing action that much?
That is a fantastic, critical thinking question. And the answer is nuanced, yes. In terms of lifestyle advice, the message is similar for 120 and 130. Intense prevention.
Okay.
However, that official diagnosis at 126, that provides the legal and therapeutic mandate to escalate interventions.
Ah, like starting medication.
Exactly, like initiating metformin. It shifts the framework. Below 126, particularly between 100 and 125, the primary nursing goal is preventing the progression to full-blown diabetes through aggressive lifestyle changes.
Right.
At 126 and above, the focus shifts to treating established disease. That means adding pharmacotherapy, setting formal monitoring schedules, screening for complications. So while the education starts earlier, 126 is the trigger point for adding drugs and intensifying the whole management plan. It signifies a different level of risk and need.
Got it. So these numbers aren't just numbers, they're gatekeepers. They signal the chronicity, the severity, and they basically turn suspicion into a confirmed clinical reality that demands a formal, stepped-up plan.
Precisely. You have to know them.
Okay, so we know how to diagnose it. Let's shift gears now to managing it, particularly type 2 diabetes, since that's the most common form we see.
Right, the vast majority of cases.
Before we even get into specific drugs, what are those foundational things, the cornerstones of treatment that absolutely have to be in place?
Yeah, you really have to think of type 2 management as a stepped approach. And the very first steps, they're entirely non-pharmacological. You just can't manage this condition effectively without nailing these 2 fundamental lifestyle adjustments.
Okay, what's number 1?
First, and arguably most important, is balanced eating, or, dietary control.
Diet. Always comes back to diet.
It does. And it's not just about cutting out sugar, though that's part of it.
Yeah.
It's managing overall carbohydrate intake, making sure meal timings are consistent to avoid those wild glucose swings.
Right.
And ensuring the diet is nutrient dense. So for the nurse doing the teaching here, the big emphasis has to be on consistency, on actually reading food labels, and understanding concepts like glycemic index or glycemic load.
So helping patients make informed choices consistently.
Exactly. Diet is really the first line of defense against that constant glucose overload and the underlying insulin resistance.
Okay, makes sense. What's the second cornerstone?
The second cornerstone is regular physical activity. It's absolutely indispensable.
How does exercise help exactly? Does it just burn sugar?
It does burn sugar, But it does more than that. Even moderate muscle contraction actually helps muscle cells take up glucose even if there's insulin resistance present. It's like it opens a back door for glucose into the cells.
How interesting. So it works around the resistance problem a bit.
To some extent, yes. And it also improves the body's overall sensitivity to the insulin it is still making. So the insulin works more efficiently. It's like a booster shot for the insulin you have.
Gotcha. So diet and exercise, they're non-negotiable. They lay the groundwork.
Absolutely. They're the foundation. Any success you have with medications is built on top of these two.
So only once those are established, and often I guess they're started right when the diagnosis happens, right?
Usually, yes. You start lifestyle changes immediately.
Okay. Then we transition into drug therapy. And the source materials, they point to specific tables, like Table 56.5 for details. But we need to highlight the #1 undisputed priority medication, the first drug usually pulled from the toolkit.
Yes. And that priority medication, the one designated as the first-line choice for almost all type 2 patients who don't have specific reasons not to take it, is metformin.
Metformin, okay, that's the name everyone knows. It's the pharmacological starting point. Now, the source didn't give us super detailed pathophysiology, but for the nursing student, we need the clinical why. Why metformin first? What's it actually doing to help fix what's wrong in type 2?
Okay, we can definitely connect its first-line status to how it works. Think about the two main problems in type 2 diabetes.
Okay.
1, the body's cells don't respond properly to insulin. That's insulin resistance. 2, the liver often goes rogue and produces too much glucose, especially overnight.
Right, hepatic overproduction.
Exactly. Metformin primarily tackles that second issue. It works mainly by decreasing hepatic glucose production.
Ah, so it tells the liver to chill out a bit.
That's a great way to put it. Think of the liver as having its foot on the glucose gas pedal. Metformin gently eases that foot up, so the liver releases less glucose into the bloodstream, particularly during fasting periods, like overnight.
Okay, that makes sense. Does it do anything else?
It does have a secondary effect. It also modestly increases insulin sensitivity in peripheral tissues, like muscle. So it helps the body use the insulin. It does still produce a bit more effectively.
So metformin basically hits both major problems right from the start. Less glucose coming out of the liver and the cells becoming a little more receptive to the insulin that's there.
Precisely. It's a really logical first step pharmacologically.
Now, what's the crucial high-yield nursing detail about metformin? Is it perfectly safe, or are there watchouts?
There's a big watch out. While it's generally very well tolerated, it has a major contraindication related to kidney function. Nurses absolutely must be aware of the risk of lactic acidosis.
Lactic acidosis. Okay, that sounds serious. How does that happen?
It's rare, but it can be fatal. If a patient's kidneys aren't working well, if they have renal impairment, metformin isn't cleared from the body properly, it builds up.
And that buildup causes the acidosis.
Yes, that buildup can precipitate lactic acidosis.
Yes.
So, checking the patient's kidney function, specifically looking at their serum creatinine and their estimated glomerular filtration rate, the eGFR, before starting metformin and periodically during therapy, is a critical nursing responsibility.
So verify kidney function before giving the first dose.
Absolutely. And you need to be alert for anything that might suddenly compromise kidney function later on.
Like what?
Like if a patient on metformin gets really sick, say, hospitalized with severe dehydration, sepsis, or acute heart failure, these conditions strain the kidneys.
Ah.
In those situations, metformin is almost always temporarily stopped, because the risk of lactic acidosis goes way up when kidney function is acutely stressed.
Got it. So understand how metformin works, reducing liver glucose output, improving sensitivity. But the absolute nursing priority is knowing its Achilles heel, renal function. Monitor the kidneys, hold the drug if the patient gets acutely ill.
That's the clinical priority in a nutshell. Know its job, know its danger zone.
All right, let's move on to insulin therapy. This feels like the ultimate hands-on nursing skill area, doesn't it? Requires precision, lots of patient teaching, and really understanding timing.
It really is, and it's crucial because, first, insulin is absolutely required for survival in type 1 diabetes. Their body doesn't make it, period.
Right. No insulin, no life for type 1.
Exactly. But it's also important to remember that type 2 diabetes is often progressive. Over time, those pancreatic beta cells can get worn out, or the insulin resistance just becomes too much for the body to handle, even with oral meds.
So type 2 patients might end up needing insulin too.
Yes. The source material indicates it's required for about 20–30% of type 2 patients eventually, just to maintain acceptable blood sugar levels and, importantly, prevent long-term organ damage.
Okay. Now, The big challenge here for the nurse, and especially for the patient learning to manage it, is that insulin isn't just one single drug.
Not at all.
There are different types designed to mimic how the body naturally releases insulin, right? Like a burst for meals and a steady background trickle.
Precisely. We talk about bolus insulin for meal coverage and basal insulin for that background 24/7 need. And knowing the different characteristics of these types, especially their onset when they start working, their peak when they work strongest, and their duration, how long they last, is absolutely vital.
Why is knowing that timing so critical?
Because it dictates everything. It tells you when the patient is most likely to experience hypoglycemia, low blood sugar. It tells you when they need to eat their meals relative to their injection. It tells the nurse when to be most vigilant about checking blood sugars or assessing for symptoms. Getting the timing wrong is dangerous.
Okay. The sources mention looking at specific tables, like Table 56.6 for these details. Let's break down the main types and their timing. This feels like core nursing knowledge.
It absolutely is. Let's start with the fast ones, the mealtime coverage insulins. First up, we have rapid-acting insulin. Think brands like Lispro, Humalog, or Aspart Novolog.
Rapid. Okay, how fast is rapid?
Incredibly fast. Onset is often within like 10 to 15 minutes.
Yeah.
Maybe 20 at most.
Wow.
It peaks, meaning its strongest effect happens usually within about 30 minutes to maybe 3 hours. And it's pretty much gone from the system within 3 to 5 hours.
Okay, so onset 10, 15 minutes, peak 30 minutes to 3 hours. What's the absolute top nursing priority with that kind of timing?
The priority is food immediacy. The patient must have their meal tray right in front of them, ready to eat before they inject this insulin. Because if they inject and then say their meal is delayed by 30 minutes, that insulin is going to peak before the food digests and absorbs.
Yeah.
They could have a serious hypoglycemic event, drop dangerously low, right as that insulin hits its maximum strength. Food first or food with the injection.
Got it. Food must be present for rapid acting. Okay, what's the next type?
Next is short-acting insulin, also known as regular insulin. Think Humulin-R or Novolin-R. This is the classic one, sometimes used IV in hospitals, but also subcutaneously for meals.
Okay, short acting. Is it slower than rapid?
Yes, slightly slower trajectory. Short-acting usually starts working in about 30 to 60 minutes. It peaks typically between 2 and 5 hours after injection, and its duration is longer, maybe up to 8 hours, sometimes a bit more.
Onset 30, 60 minutes, peak 2, 5 hours. So the timing advice for meals is different here.
It is. The clinical teaching for the nurse is specific. Instruct the patient to administer this type 30 to 60 minutes before the meal.
Why the wait?
That waiting period allows the insulin time to get absorbed and start working, so its peak effect aligns better with the rise in blood sugar that happens after you eat and digest the meal. Timing is key to match the insulin peak with the food peak.
Okay, so rapid is eat right now, short is inject, then eat in 30, 60 minutes. These two cover meals. What about that background steady insulin, the basal coverage?
Right. For the basal needs, we move into the longer-acting types. First, there's intermediate-acting insulin, most commonly NPH, Humulin N, Novolin N. This is often the one that looks cloudy.
Ah, the cloudy one. How does its timing differ?
NPH has a slower onset, maybe 1 to 2 hours, but the key thing is it has a more pronounced peak, usually somewhere between 4 and 12 hours after injection. Its duration is longer too, maybe 14 to 18 hours, sometimes up to 24.
Peak at 4 to 12 hours. That seems like a wide window. Does that create any specific risks?
It does. Because of that distinct peak, especially if it occurs overnight while the patient is sleeping, there's a higher risk of nocturnal hypoglycemia with NPH compared to the newer basal insulins. It often requires twice-a-day dosing to provide full 24-hour coverage and cover periods between meals.
Okay, so NPH cloudy has a peak, risk of overnight lows. Are there options without that pronounced peak?
Yes, and that's where the modern long-acting and ultra-long-acting basal insulins come in. Think Glargine, Lantus, Pasaglar, or Ditamir, Levemir for long-acting, and Degludec, Tresiba for ultra-long-acting.
What's special about them?
They're specifically engineered to have a very slow, steady release with minimal or essentially no peak at all. They provide a continuous, flat background level of insulin.
Ah, like a true trickle.
Exactly. Glargine and Detamir typically last around 24 hours, sometimes dosed once or twice daily. Degludec can last even longer, well over 24 hours, offering more flexibility. The key benefit is a much lower risk of hypoglycemia, especially overnight, because there isn't that big peak in action. They're usually given once a day, often at the same time each day, regardless of meals.
Okay, that makes sense. So the highest yield piece of knowledge here, especially regarding safety, seems to revolve around understanding that peak time.
Absolutely.
If I'm the nurse and my patient just got their morning dose of, say, short-acting insulin at 8 a.m.,
Yep.
I know that the danger zone for hypoglycemia is roughly between 10 a.m. and 1 p.m., 2 to 5 hours later. That's when I need to be extra vigilant, checking their sugar or at least asking them how they feel, looking for those signs.
That is precisely the core clinical judgment. The peak time equals the time of highest insulin action, which equals the greatest risk of low blood sugar. Misassessing during that peak window, and you might miss an impending crisis.
And what are those signs of hypoglycemia we should be looking for?
The classic signs are things like nervousness, shakiness, sweating, maybe confusion, irritability, rapid heartbeat, dizziness, sometimes hunger. Recognizing those, especially during that expected peak time for the specific insulin they took, is a critical, life-saving nursing skill.
Okay, super important. Now, beyond just knowing the types, the actual preparation and administration of insulin, these are fundamental nursing skills too, right? Directly tied to safety and making sure the insulin works correctly.
Absolutely critical. Let's talk about mixing insulin first.
Mixing. Can you mix different types?
You sometimes need to, particularly mixing a rapid or short-acting, which are clear, with an intermediate-acting NPH, which is cloudy. While combination pens are more common now, you still need to know the rule if you have to draw them up separately into one syringe.
Okay, what's the rule?
The rule is absolute and must be followed every time. Clear to cloudy. You must draw the clear insulin, the rapid or short-acting, into the syringe first. Then you draw the cloudy insulin, the MPH, into the same syringe.
Clear before cloudy. Why? What happens if you mix it up? Does it explode?
No, it won't explode. But it matters intensely because you risk contaminating the vials. If even a tiny bit of the cloudy NPH gets into the clear, rapid, or short-acting vial, it can potentially buffer or slightly alter the rapid onset of that clear insulin. It could make it act a little slower or less predictably.
Yeah.
By drawing the clear first, you ensure the purity and rapid action of that mealtime insulin vial remains intact. You protect the fast one.
Okay. Protect the integrity of the fast-acting vial. Got it. Clear first, then cloudy. Next up, injection sites. Where do we tell patients to inject?
Insulin is given into the subcutaneous fat layer, not the muzzle. The sources specifically list 4 large approved areas that have good subcutaneous tissue for consistent absorption.
Okay.
The abdomen, but importantly tell them to avoid a 2-inch circle right around the belly button. The upper outer arms, the upper outer thighs, and buttocks, sort of the upper outer quadrant.
Abdomen, arm, thigh, buttocks.
Got it. Now let's drill down on maybe the most critical detail about giving the shot, the one that often gets glossed over but has huge long-term consequences: site rotation. It's not just don't use the same spot, is it?
No, it's much more specific than that, and this detail is absolutely paramount for achieving stable, long-term blood sugar control. The correct instruction is to rotate injection sites within one anatomic area before switching to a completely different area.
Okay, break that down. What does rotate within one area actually look like?
So let's say the patient chooses to use their abdomen for their morning injections this week. On Monday, they inject in one spot. On Tuesday, they move about a finger's width away. Wednesday, another finger's width. They systematically use different spots across their entire abdomen, keeping injections about an inch apart.
Okay.
Before they then decide, okay, next week I'll switch to my left thigh, and then they'd rotate systematically within the thigh area. Why is rotating within an area first, instead of just randomly jumping from belly Monday to arm Tuesday to thigh Wednesday the right way? What problem are we preventing?
We are primarily preventing lipodystrophy. This is a change in the subcutaneous fat at the injection site. It can be either lipohypertrophy, which is like a spongy lump, or thickening of the fat tissue from repeated injections.
Okay.
Or, less commonly now, lipoatrophy, which is a dimpling or loss of fat tissue. If a patient keeps injecting into the same small spot over and over, they develop these areas.
And why is injecting into those lumpy or dimpled areas bad?
Because the tissue there is essentially scarred or altered. Think of trying to inject medication into a tough piece of scar tissue versus soft, healthy fat.
The absorption would be different.
Dramatically different. Insulin absorption from lipodystrophic sites becomes highly erratic and totally unpredictable. One day they might inject near a lump and get very poor absorption, leading to high blood sugar. The next day they might hit a spot nearby that absorbs okay, maybe even too fast, risking low blood sugar.
So it causes wild, unexplained swings in their glucose levels.
Exactly. It completely undermines any attempt at consistent control. By rotating systematically within one area for, say, a week or a month, the patient gets relatively consistent absorption from that general body region, while allowing the previously used spots enough time to heal before they circle back.
Wow.
This seemingly small administration detail, rotate within one site before switching sites, can totally derail an otherwise perfect insulin plan if it's ignored. It's a major focus for nursing education.
Okay, we're shifting now into maybe the most urgent territory of diabetes care, the acute complications. This is where that priority nursing judgment gets tested under pressure. Rapid recognition, immediate, high-stakes actions.
Absolutely. These are medical emergencies.
We really need to compare and contrast the two major hyperglycemic life threats because telling them apart quickly is key, right?
It's critical. When a patient with diabetes presents with severe, uncontrolled high blood sugar, the nurse has to instantly start thinking, is this diabetic ketoacidosis, DKA, or is it hyperglycemic hyperosmolar state, HHS? Because the answer dictates the immediate priorities for fluids, insulin, and electrolytes. They look similar in some ways, but the underlying pathology and urgent needs are quite different.
Okay, let's paint a picture. Scenario 1. A younger patient, maybe known type 1, maybe newly diagnosed, comes into the ER looking really sick. What specific signs and symptoms scream DKA?
Okay, for DKA, think sudden onset. It often comes on quickly, maybe over hours or a day or two. It's frequently triggered by something like an infection, or maybe they missed several insulin doses.
Okay, sudden onset. What's the core problem in DKA?
The core problem is a near absolute lack of insulin. Without insulin, the body can't use glucose for energy, so it panics and starts breaking down fat at a massive rate.
And breaking down fat leads to...
It leads to the production of ketones, which are acidic byproducts.
Yeah.
So the presence of significant ketosis is the absolute hallmark of DKA. Their blood becomes acidic.
And clinically, how does that ketosis, that acidosis manifest? What can the nurse see or smell?
Two key things. First, the smell. Their breath might have a distinct fruity or acetone-like odor due to the ketones. Second, the breathing pattern. They often develop Kussmaul respirations.
Kussmaul breathing, describe that again.
It's very deep, rapid, almost gasping breaths. It looks labored. The body is desperately trying to compensate for the metabolic acidosis by blowing off excess carbon dioxide, which is an acid in the blood. Seeing Kussmaul breathing is a huge red flag for DKA.
Fruity breath, Kussmaul breathing, got it. What else do we see physiologically? What about their hydration and sugar level?
They're typically profoundly dehydrated because the high blood sugar causes osmotic diuresis, basically. Sugar spills into the urine and pulls water out with it. And their glucose level is usually greater than 300 milli-GDL, glucose 300.
Right.
It could be higher, 400s, 500s, but sometimes it's not astronomically high, especially if they've been vomiting.
So 300 glucose, dehydration, and the key is the acidosis from ketones.
Exactly. And the labs will confirm it. Low blood pH, low bicarbonate level. The urgent threat in DKA is the severe metabolic acidosis disrupting cellular function, along with dehydration and electrolyte imbalances, especially potassium.
Okay, clear picture of DKA. Now let's pivot. Scenario 2. Maybe an older adult, known type 2 diabetes, maybe lives alone, has had a bad flu for a week, getting weaker, more confused. What suggests hyperglycemic hyperosmolar state, HHS, instead?
For HHS, think gradual onset. This usually develops much more slowly than DKA, often over days or even weeks. It's frequently precipitated by an illness or infection in an older adult with type 2, especially if their fluid intake has been poor.
Gradual onset. What's the key difference in the underlying physiology compared to DKA?
The key difference is that in HHS, the patient usually still produces some small amount of insulin. It's not enough to control their blood sugar, but it is often just enough to prevent the massive fat breakdown and therefore prevent significant ketosis.
Ah, so no ketones?
No significant metabolic acidosis. So generally, ketosis is absent or minimal in HHS. You won't typically see that fruity breath, and critically, you won't see Kussmaul respirations. Their breathing might be shallow and rapid due to dehydration, but not that deep, driving pattern of Kussmaul.
Okay, so if it's not acidosis killing them, what is the primary life-threatening feature of HHS?
The defining problem in HHS is the extreme hyperosmolarity of the blood. Their glucose levels get incredibly high, way higher generally than in DKA. We're talking extremely high glucose levels, often greater than 600 milli-GDL, glucose 600, sometimes even over 1,000.
Wow, over 600. What does that extreme glucose level do to the body?
That massive amount of sugar in the bloodstream makes the blood incredibly concentrated, or hyperosmolar. This high concentration acts like a sponge, pulling huge amounts of water out of the body's cells, including brain cells.
Pulling water out of brain cells. That sounds bad.
It's very bad. The brain cells shrink, leading to the hallmark symptom of HHS, altered central nervous system, CNS function. This manifests as profound confusion, lethargy, drowsiness, sometimes focal neurological deficits like seizures or stroke-like symptoms, and it can progress rapidly to coma. They are also severely catastrophically dehydrated, even more so than in DKA usually.
So the critical distinction. DKA is mainly a crisis of acidosis from ketones. With glucose 300, small breathing is key. HHS is mainly a crisis of extreme hyperosmolarity and dehydration, leading to neurological collapse with glucose often 600, and no significant acidosis or small breathing.
You nailed it. That's the core contrast every nurse needs to recognize instantly.
And how does recognizing that difference drive the immediate priority intervention?
It dictates the immediate focus. While both conditions obviously need IV insulin to gradually lower the blood glucose, and both need fluids.
But the emphasis is different.
Yes. In HHS, the absolute number one immediate overwhelming priority is aggressive fluid resuscitation. That patient is facing potentially lethal dehydration and circulatory collapse due to massive fluid loss, and the hyperosmolarity is directly damaging their brain.
So fluids first and foremost in HHS.
Fluids, fluids, fluids. Usually starting with isotonic saline to restore intravascular volume, and then potentially switching to hypotonic fluids later to rehydrate the cells cautiously. The goal is to restore perfusion and gently lower that serum osmolality to help the brain.
And in DKA, is fluid less important?
Fluid is still vital in DKA because they're dehydrated, but the management is often more complex initially because you're simultaneously dealing with the severe acidosis and the very tricky electrolyte shifts, especially potassium, that happen as you give insulin. Insulin drives potassium back into cells, potentially causing dangerous hypokalemia if you're not replacing it proactively.
Oh.
So in DKA, it's fluids plus careful insulin management plus very close electrolyte monitoring and replacement, particularly potassium right from the start. In HHS, the initial overwhelming focus is just volume, volume, volume to combat the profound dehydration and hyperosmolarity.
Wow. So recognizing small breathing versus profound altered mental status, knowing those glucose thresholds around 300 versus 600 plus, and understanding the acidosis versus osmolarity difference, that really dictates your first move and potentially saves a life.
It absolutely does. This comparison DKA versus HHS is high-yield, life-saving nursing knowledge.
Okay, we've covered the day-to-day management with insulin timing, and we've covered the acute crises like DKA and HHS. This last section really focuses on the long game, doesn't it? The chronic complications.
Yes, the damage that happens slowly, silently over years of exposure to high blood sugar.
It seems like chronic high glucose acts almost like a corrosive agent throughout the body, particularly on blood vessels. What are the main systems that get hit hard by long-term, poorly controlled diabetes? What does the nurse need to be constantly screening for?
You're right. Sustained hyperglycemia is toxic, especially to blood vessels. We usually divide the chronic complications into microvascular, affecting tiny blood vessels, and macrovascular, affecting large blood vessels.
Okay, let's start with the microvascular ones. Small vessels, what gets damaged there?
Three main areas traditionally. First, the eyes. High sugar damages the tiny capillaries in the retina, leading to diabetic retinopathy. This is a leading cause of blindness in working-age adults. Diabetes also accelerates the formation of cataracts.
Eyes. Okay, what else?
Second, the nerves. Damage to small blood vessels supplying the nerves, plus direct glucose toxicity, leads to diabetic neuropathy. This typically starts in the feet and hands the classic stocking glove distribution, causing numbness, tingling, burning pain, or sometimes complete loss of sensation. This loss of feeling is a crucial setup for foot problems.
Right, if you can't feel injury. Eyes, nerves. What's the third microvascular target?
The kidneys. Damage to the tiny filtering units, the glomeruli, leads to diabetic nephropathy. Over time, this can progress to kidney failure, requiring dialysis or transplant. In fact, diabetes is the leading cause of end-stage renal disease. Nurses play a key role in early detection by screening for microalbuminuria, tiny amounts of protein leaking into the urine, which is an early warning sign.
Wow. Retinopathy, neuropathy, nephropathy, the compithes, that's the microvascular triad. What about the big blood vessels, the microvascular complications?
This is where diabetes dramatically accelerates atherosclerosis, the hardening and narrowing of arteries throughout the body. It affects the major highway.
Leading to what kinds of problems?
It significantly increases the risk for hypertension, high blood pressure, which then further damages vessels. It causes severe peripheral vascular disease, PVD, drastically reducing blood flow to the legs and feet. It massively increases the risk of stroke and generalized heart disease, including heart attacks and heart failure.
So basically, it speeds up the aging process of the entire cardiovascular system.
That's a very good way to think about it. The nurse's role here involves intensive monitoring and management of blood pressure, cholesterol levels, lipids, and encouraging smoking cessation, all crucial for mitigating these huge macrovascular risks.
Okay. Eyes, nerves, kidneys, heart, brain, peripheral arteries. Is there anything else systemically affected?
Yes, there's one more overarching complication that makes everything else worse: immunosuppression.
The immune system takes a hit too. How?
Chronic high blood glucose actually impairs the function of immune cells, particularly white blood cells like neutrophils. They don't move as well, they don't engulf bacteria as effectively. The whole infection-fighting machinery gets sluggish and gummed up.
So people with diabetes are more likely to get infections.
Much more likely.
Mm.
And, critically, once they do get an infection, their body has a much harder time fighting it off and healing the tissue, especially if circulation is already compromised by PVD.
That seems hugely important. A minor cut could become serious.
Exactly. This immunosuppression context is vital for the nurse. It means you have to be hypervigilant for signs of infection anywhere: lungs, urinary tract, skin, teeth, because even a seemingly minor infection can rapidly escalate into sepsis in a patient with poorly controlled diabetes.
Okay, so we have this devastating combination. Neuropathy, can't feel injuries, PVD, poor blood flow for healing, and immunosuppression, can't fight infection effectively. Given that perfect storm, let's focus intensely on the area where nursing intervention seems most critical for prevention: the diabetic foot.
Yes, this is where those three complications converge with potentially catastrophic results.
The source materials even include images of foot ulcers, highlighting how severe they can get. Why does something seemingly small, like a blister or a tiny cut on the foot, pose such a massive risk, even leading to amputation?
It really is that perfect storm. The patient might step on something sharp or get a blister from an ill-fitting shoe, and because of neuropathy, they don't feel any pain, so the initial injury goes unnoticed.
Okay, step 1, no warning signal.
Step 2. Because of PVD, there's poor blood flow to the area. The body can't deliver enough oxygen, nutrients, or infection-fighting cells to the site to start the healing process effectively.
Step 2, no resources for repair.
Step 3. Because of immunosuppression, any bacteria that inevitably get into that small break in the skin face a weakened defense system. The infection takes hold easily and spreads rapidly through the compromised tissue.
Step 3, no defense against invaders.
Then that's how a tiny unfelt injury in a poorly circulated immunocompromised foot can quickly blossom into a deep, non-healing ulcer, potentially involving bone, leading to gangrene, and ultimately amputation. It's a devastating cascade.
Which makes preventing that initial injury paramount. This sounds like the absolute highest priority patient teaching topic for any nurse caring for a diabetic patient.
It absolutely is. Mastering diabetic foot care education is a core nursing competency.
Okay, let's break down the prevention protocol in detail. These are the specific instructions the nurse needs to hammer home. Where do we start? Hygiene.
Yes, start with hygiene, but with a very critical detail. Patients should bathe their feet daily using lukewarm water, test it with their elbow or a thermometer, not their feet, because of neuropathy.
Right, don't trust their sensation.
Exactly.
Yeah.
After washing, they need to dry their feet thoroughly, especially between the toes. This is crucial. And when they apply lotion to keep the skin from cracking,
Yes.
they must be explicitly told not to put lotion between the toes, only on the tops and bottoms.
Okay, why is moisture between the toes such a specific enemy? We mentioned it briefly, but let's reinforce it.
Because that trapped moisture creates the perfect dark, warm, damp environment for fungal infections like athlete's foot to thrive.
And fungal infections lead to.
Fungal infections cause itching and microscopic cracks in the skin. Even tiny cracks are an open door for bacteria in someone who is immunosuppressed. Preventing moisture between the toes helps prevent the fungal infection that often provides the initial entry point for bacteria. It's a key first step in barrier protection.
Got it. Dry thoroughly, no lotion between toes. What's next in protecting the footwear?
Footwear is huge. The rule is always wear closed-toe shoes that fit well. Emphasis on well-fitting. Shoes shouldn't pinch or rub anywhere.
No going barefoot, ever.
Never walk barefoot, not even inside the house on soft carpet. It's just too easy to step on something small or stub a toe without realizing it.
What about new shoes?
New shoes need to be broken in slowly. Wear them for only an hour or two the first day. Then take them off and carefully inspect the feet for any red spots or areas of irritation. Gradually increase the wearing time.
Okay. What about things people might think are helpful but are actually dangerous?
Yes, there are critical don'ts. We already said no walking barefoot. Also, never use heating pads or hot water bottles on the feet. Neuropathy can prevent them from feeling a burn until it's severe.
Okay, no external heat sources.
Avoid soaking feet for long periods. While cleaning is good, prolonged soaking can actually dry out the skin excessively or lead to maceration, skin breakdown, making it more fragile.
Interesting. No soaking. What about calluses? Should they try to remove them?
Absolutely. Do not shave or cut calluses themselves. Using razors or sharp instruments carries an extremely high risk of accidentally cutting the skin. Calluses should only be managed by a podiatrist or a trained healthcare professional.
Okay, so protect the feet with shoes, break them in slowly, avoid barefoot walking, heating pads, soaking, and self-treating calluses. Since they can't rely on pain, what's the active surveillance step?
Daily foot inspection. This is non-negotiable. Every single day, the patient needs to visually inspect all surfaces of both feet,
Looking for what?
looking for anything abnormal. Redness, swelling, blisters, cuts, scratches, or any breaks in the skin, no matter how small. They also need to check for changes in color or temperature.
How can they see the bottoms of their feet?
This is key. Teach them to use a mirror on the floor to get a clear view of the soles and heels. If they can't bend easily or have vision problems, a family member should be taught how to help with the daily inspection. This daily check is their substitute warning system.
Daily inspection with a mirror. Got it. What about toenail care? That seems like another potential entry point for infection.
It is. The instruction is very specific. Trim toenails straight across. Never curve the edges down into the corners. After trimming, gently file any sharp edges with an emery board.
Why straight across?
Cutting down into the corners dramatically increases the risk of creating an ingrown toenail, which breaks the skin and invites infection. Again, for patients with severe PVD, vision problems, or bad neuropathy, professional trimming by a podiatrist is often the safest route.
Okay. And what if they do find a small problem, like a blister or a corn?
They must avoid all home remedies, self-medicating, and over-the-counter foot products, like harsh corn removers. Any blister, cut, corn, callus, ingrown nail, or sign of infection needs to be evaluated by their healthcare provider or podiatrist promptly. Don't wait. Don't try to fix it themselves.
Okay, that covers protecting the skin barrier and inspection. What about the PVD aspect? Can we do anything to help the already poor circulation?
Yes, there are things to teach to maximize the blood flow they do have and prevent further constriction. Circulation management is vital.
Like what?
Teach them to avoid prolonged periods of sitting, standing still, or crossing their legs. These positions can compress blood vessels and impede flow. They should get up and move around frequently if possible.
Okay, keep moving. What about socks and clothing?
They should wear clean, dry socks every day. Ideally, loose-fitting socks made of cotton or wool blends that wick moisture away. White socks are often recommended because drainage or blood from an unnoticed injury will show up clearly.
White socks for early detection. Good tip.
And critically, don't wear constricting clothing. No tight socks, no garters, nothing that leaves indentations on the skin or could restrict blood flow to the lower legs and feet.
Wow, that is an incredibly detailed list just for foot care. It really underscores how much nursing time and effort needs to go into this specific education.
It's arguably one of the most impactful preventive interventions a nurse can deliver for a patient with diabetes. It requires patience, repetition, and checking the patient's understanding and technique.
So what happens if, despite all this, prevention fails and a patient does develop a foot ulcer? What are the key nursing interventions then, according to the sources?
If an ulcer develops, the focus shifts to active wound management and preventing worsening. The priorities become: first, tight control of diabetes. You simply cannot heal a wound effectively if blood sugars are high. Hyperglycemia impairs healing and feeds infection.
Okay, get the sugar down. What else?
A second, wound care, which might involve debridement, the removal of dead or infected tissue by a specialist to allow healthy tissue to grow. Nurses will be involved in dressing changes and monitoring the wound bed. Third, intensive patient education on recognizing signs and symptoms of worsening infection. Teach them exactly what to look for: increasing redness, spreading around the wound, more swelling, foul odor, increased pus or drainage, fever, and to report it immediately.
And fourth,
you have to constantly reinforce teaching prevention of future foot ulcers. Just because they have one ulcer doesn't mean the rules go away. You have to reteach and reinforce that entire comprehensive foot care protocol we just discussed, because they are now at even higher risk for another one.
It really drives home the point that diabetic foot care isn't a one-time lecture. It's a continuous process of assessment, education, and reinforcement throughout the patient's life.
Absolutely. It's long-term, high-priority nursing care.
Okay, this has been an incredibly thorough deep dive. We've covered the precise numbers for diagnosis, the rationale and risks for starting metformin, the critical timing and administration rules for different insulins, the stark differences between DKA and HHS crises, and now this incredibly detailed life-saving protocol for chronic foot care.
It's a lot, but it's all crucial.
To try and synthesize the absolute must-know takeaways for the nursing student listening, you have to know those 4 diagnostic numbers, the 126 FBG, the 200 for random or GTT, the A1C of 6.5% or higher because they are the official triggers.
Got to know them cold.
You need to understand why metformin is first-line primarily reducing liver glucose output, but your priority nursing concern is kidney function and that risk of lactic acidosis.
Check those kidneys. Hold up acutely ill.
And you absolutely must be able to clinically differentiate DKA, think acidosis, ketones, small breathing, glucose, often 300 from HHS, think extreme hyperosmolarity, dehydration, altered CNS function, glucose, often 600, no small, because that difference drives your immediate fluid management priorities.
That distinction is life or death sometimes.
Yeah.
But you know, what's really fascinating when you step back and look at all this, and what I hope the nursing student really holds on to, is how much power lies in the most seemingly basic interventions.
How so?
Think about it. Teaching a patient to meticulously dry between their toes, or to use a mirror every single day to check the bottoms of their feet. These small daily actions carry the potential weight of preventing a catastrophic infection, a hospitalization, even a surgical amputation down the line. The real art of nursing and diabetes care is often found in making those small, tedious daily prevention details feel just as urgent and important to the patient as rushing to the ER during an acute crisis like DKA. It's about elevating the mundane to the level of critical prevention.
That's a really powerful way to frame it, prioritizing the power of those small details. Okay, and for a final provocative thought for you, our listener, to take away and maybe mull over.
Okay.
We spent some time talking about how chronic diabetes causes this generalized immunosuppression, right? Making patients more vulnerable to infections and hindering healing all over the body.
Yes, that impaired immune function is key.
So, thinking beyond just the feet, when you are assessing any patient with diabetes, how does knowing about their suppressed immune status change your assessment priorities for all potential infection sites? How much more aggressively do you need to investigate a cough, listen to lung sounds for potential pneumonia, ask about urinary symptoms for a UTI, or even look closely at their gums for dental abscesses? Knowing their body simply can't mount a normal defense.
That's a great point. It requires a higher index of suspicion across the board.
Exactly. So encourage yourself to really delve deeper into that interplay between the chronic vascular damage of diabetes and this compromised immune response. How does it change your approach to seemingly unrelated complaints?
Yeah, think systemically about that vulnerability.
Thank you so much for joining us on this deep dive into diabetes mellitus. We truly hope this comprehensive review has armed you with not just the knowledge, but also that critical clinical priority judgment you need to excel in caring for patients with this complex condition.
Thanks for listening.